Welcome to exploring the new APA Clinical Practice Guideline for the treatment of depression across three age cohorts webinar presented by the American Psychological Association. Thank you for joining us. APA is delighted to bring you this webinar, which helps guide psychologists on delivering research-based treatment for depression under the new APA Clinical Practice Guideline for the treatment of depression across three age cohorts. So let's begin with a few housekeeping notes. At this time, all lines are muted. If you require technical support, please submit questions within the Tech Support tab on the right side of your screen, not to be confused with the Q&A tab. You should be able to see the slides live. If you have a technological issue, try a different browser. To view the slides in full screen mode, click the screen icon next to Live in the lower right side of your screen. Right side of the slide. Press Escape to exit full screen. To access the PDF file of today's slides, please download them from the link provided on your screen or from the resources link in your Beacon Live course dashboard. We encourage you to submit questions about today's topic throughout the program using the Q&A tab on the right side of your screen, and questions will be answered during the last 15 minutes of the webinar. Due to the time constraints, we will not be able to answer all the questions. If you would like to rewatch this session, a recording will be available within 5 to 7 business days of the original air date. You will be able to access it from your course dashboard. To obtain the 1.25 APA Continuing Education credits offered for this webinar, you must click OK when you see the attendance verification box appear on your screen during the webinar. All you need to do is click OK. Remember to respond to all attendance verifications you see. You must also complete a webinar evaluation, so stay online throughout the conclusion of the webinar, and you will see a pop-up appear on your screen with access to the evaluation. A CE certificate will be emailed to you and will also be available for download in your course dashboard. If you have any questions about continuing education credits, please email cpe@apa.org. And it is now a pleasure to introduce today's first presenter. Dr. Raquel Halfond is the Director of Clinical Practice Guidelines in Practice Research and Policy at APA, the American Psychological Association. She is also a clinical child psychologist. Please go ahead.
Thank you. Hi, everyone. Thank you for joining us here today. We're excited to have each of you. So I'm going to start out by giving you a brief overview of guideline development and a little slice of the history of guideline development for APA. And then my colleagues, who are members of the panel, are going to go through and give you an overview by age cohort of the different parts of the guideline itself. After that, my colleague, Ms. Jones, is going to talk with you about her experience being a community member on the guideline panel. After that, I'm going to show you a quick overview of some resources that are available for you to use. And then lastly, we're going to wrap up with some questions and answers. So first is, what is a clinical practice guideline? This is an area about which we get a lot of confusion and we tend to get a lot of questions. APA has two main types of guidelines: professional practice guidelines and clinical practice guidelines. Now, professional practice guidelines, APA has been doing these for many years, and APA has quite a few of these already developed. These tend to focus on psychologist behavior and how to work with, for example, particular populations. And these are really geared towards psychologists. Clinical practice guidelines, on the other hand, are newer for APA, and these tend to be focused on particular disorders or conditions. They will discuss interventions and recommendations for these that are based on a systematic review of the literature. And in our presentation today, we're going to focus on this second type of guideline, the clinical practice guideline. So how's APA doing this? So brief slice of history. In 2010, APA decided that the time was right to begin to develop these guidelines, and APA's board of directors directed the formation of the Advisory Steering Committee, or what we call our ASC. This is the group that provides oversight for the guidelines initiative, and they make recommendations for methodological methods and such. And this group has been meeting regularly in person and via conference call since then, and they decided in 2012 that the first 3 guidelines topics for APA would be post-traumatic stress disorder, PTSD, obesity and overweight in children and adolescents, and then also depression. So by the end of 2012, these initial guideline panels had been formed, and the ASC decided to go forward with using the practices by the former Institute of Medicine. So what do guidelines offer? So they really help providers and patients to make informed choices about treatment. They provide a summary of the relevant literature, the research literature. Now, many of us subscribe to journals, and each month that journal shows up, and you have very good intentions to read it, and but we also get busy, and sometimes it goes in a set aside, and then the next month the next one goes, and so maybe developing a little bit of a pile. And so what these guidelines do is they go through and they summarize the research literature for the busy provider within the particular parameters of that guideline. Guidelines are not a standard of care. They are to be used within the evidence-based practice and psychology model. So with this model, many of you, I'm sure, are familiar. You've got your 3 intersecting, overlapping circles where you have patients' values and preferences, culture, individual characteristics. In one circle, you've got clinician expertise in another circle, and then you have best available research evidence in the third circle. 3 of them are overlapping for making decisions. And these clinical practice guidelines really speak mainly to that research circle. That's really where they focus. So they are to be used within the context of shared decision-making together with the clinician and the patient. And they provide a voice for psychology as well. So the healthcare landscape today, clinical practice guidelines are widely used. They are widely produced by many organizations. And so developing these really provides a voice for psychology within this broader healthcare. So these, on this slide, I have a brief summary of what are the IOM standards for guideline development. So you see the top, transparency. So being transparent is a very important part of it. Resolving conflicts of interest, to disclose and divest. Now, question for the moderator. My screen just went really dark.
And Raquel, could you try to, in the top left corner of the presentation, if you could just reload your page? That may have been due to the alert that I sent.
Okay, I'll just click reload. Okay, thank you. So it's also important for the panels to be multidisciplinary and balanced. There is a concept of adversarial collaboration. So if you have somebody on a panel who maybe brings in a certain viewpoint, it's important to counterbalance it with other viewpoints as well. They are based on a systematic review of the literature. There's a rating of the quality and the recommendations' strength and the quality of the evidence. The recommendations should be framed as actionable statements. There's a public comment period, and the guideline is updated as necessary. So this is a brief diagram of how this process works. So really fundamentally, you've got your systematic review, and then you should arrow really leading to your clinical practice guideline. Systematic review, you've got what we call your PICOs, your populations, interventions, comparators, outcomes, timing, and setting. Those are all pre-specified in advance, and that leads into your clinical practice guideline. Clinical practice guidelines for APA are based on 4 main factors. They're based on the strength of the evidence, the balance of the benefits versus the harms of an intervention, patients' values and preferences, and the applicability of evidence to real-life patients. And this next slide here is really just a kind of a fancier picture of what I just talked you through. So you see on top, you see the systematic review process, the PICOs leading into, we see the quality of the evidence and the strength of the evidence, and that's essentially handed off to the guideline panel who completes a review of those 4 factors: the evidence, the balance, the values and preferences, the applicability, and then those 4 factors together lead into the actual recommendations. Okay, and then this next slide here is just our roster of who our guideline panel members were. It was led by Dr. John McQuaid. Dr. Elizabeth Lynn was the vice chair, and here you can see here all of our esteemed members. We had a really great group of individuals. Okay, so the next presenters are going to go into this in more detail, but briefly looking at scope and key questions, there were 3 age cohorts. There were children and adolescents, there were general adults, and then there were older adults. There were 10 underlying reviews used for this guideline, and that's systematic reviews and meta-analysis. Now, for comparison, our 2 other clinical practice guidelines, PTSD and obesity, each of those used only 1. So these guys were ambitious, and they used 10, which is very impressive. They included major depressive disorder, persistent depressive disorder, subsyndromal. They looked at efficacy and risks of harm to psychotherapy or complementary and alternative medicine treatments. They looked at efficacy of pharmacotherapy for children and adolescents only. And then they looked at comparative effectiveness and risk of harms for psychotherapy, complementary and alternative medicine, and compared with each other or with pharmacotherapy. And our panel was very interested in whether these are moderated by subgroup characteristics, but unfortunately there was really not enough information and not enough data available to them to be able to really answer those questions. So that was something else they talked about a lot in their guideline. Okay, so then now we're going to go ahead and move on to the guideline recommendations by age cohort.
Hi, this is Laura Muffson. I'm going to talk to you about the child and adolescent depression cohort. Hopefully you can hear me with my slightly hoarse voice today. I'll do my best. So as Dr. Halfon talked about, clinical practice guidelines have their place in our evidence-based practice. And one of the reasons why the ones for depression are so important, particularly when we think about children and adolescents, is because the rates of depression in this cohort are really a public health problem. As you can see on the slide, there's an increasing rate of depression in children and teens and adults, but particularly in adolescents, we've seen a 2.6% increase in those teens experiencing a major depressive episode. And more startling is, despite the fact that we know all of these children and adolescents have depression, less than 1% of these children and adolescents in the U.S. are receiving outpatient treatment for depression each year. So what we hope to do with the clinical practice guidelines is to increase the number of adolescents and children who have access to effective treatment. And to do that, we need to let practitioners know what the evidence base is for specific treatments so that you can consider these treatments along with understanding your patient's context of depression to figure out how to provide the best care for your patients. And most importantly, treating depression is an important step to preventing teen suicide. So as we know about teen depression, it's got significant impairment in functioning related to school and work and their social roles. So we think about the need for early intervention in order to prevent impairments that go on to have further impact into adulthood. We also want to treat depression to prevent suicidality. Nearly 30% of adolescents with major depression reported some form of suicidality in the past year. So it's important both to prevent the impairment with depression and as well as for suicide prevention. So what is currently being done to address the increase in rates? There is increased attention, particularly to the increase in rates in our racial and ethnic minorities. Most recently, there have been news reports and new papers coming out about the increased rate, particularly in Black children and teens, increased rates of suicide. And so there have been task force and work groups that have formed and really to think about our treatment recommendations and how to really refocus our efforts on figuring out how to provide interventions to prevent further increases in these rates. So the treatment recommendations from the work of our panel are as follows. After careful review of the available meta-analyses and systematic reviews that met our criteria, we found that for children, there's insufficient evidence to recommend a particular psychotherapy or pharmacotherapy based on the literature. This is in part due to the fact that many of these studies methodologically didn't have a comparator treatment group. The active treatment was compared to waitlist or no treatment, which doesn't help to provide conclusive evidence for the efficacy of an intervention. For the adolescent literature, we, after careful review, the recommendation was for cognitive behavior therapy or interpersonal psychotherapy for adolescents as having the most evidence for their efficacy, and for fluoxetine for major depression if considering pharmacotherapy. If fluoxetine was not an option, perhaps they've already tried that medication, it wasn't effective, the panel recommends shared decision-making about other medication options. There wasn't enough evidence to recommend another medication over another. Similarly, there's insufficient evidence to recommend any one psychotherapy over another, such as psychodynamic or family therapy, because most of the studies that have been included in these systematic reviews didn't compare one psychotherapy to another psychotherapy. So we don't have enough evidence to say whether family therapy is better than psychodynamic psychotherapy. So we can't recommend one over the other at this point. In terms of the two treatments that were recommended, just to familiarize you, cognitive behavior therapy really stems from the work of Aaron Beck and focuses on modifying cognitions, negative cognitions, and dysfunctional behavior patterns. The therapist would target these distorted beliefs, work on improving the way that they're processing information rather than viewing it only through a negative lens, and then working as well on their dysfunctional emotions. In interpersonal psychotherapy, the therapist really is looking to target depressive symptoms in the context of the interpersonal relationships that may be linked to the depressed mood, and targeting how to improve these interpersonal relationships by improving the ability to identify and express emotions, communicate more effectively within the relationship, and focus on interpersonal problem-solving skills. In terms of the studies that we looked at, there are multiple RCTs that demonstrated the efficacy of reducing symptoms of depression in adolescents, both for cognitive behavior therapy and interpersonal psychotherapy. Again, I just want to highlight that the comparison conditions in these studies do not include behavior therapy, play therapy, problem-solving therapy, dynamic therapy, or manualized supportive psychotherapy. So again, that's what prevents us from being able to say one treatment is more effective in comparison to these other therapeutic approaches. In terms of the current state of the literature, IPTA has an evidence base that's focused on a more racially diverse sample of youth than cognitive behavior therapy. However, the shortcomings of the literature on IPTA include that their studies don't have as much long-term outcome data, and there's fewer studies on IPTA than there are for CBT. while there are more studies on CBT, more often the CBT is compared to a waitlist control rather than another psychotherapy. And therefore, the effect sizes for the outcomes for the CBT arm may be overstated. It's possible, and people have written about that, the effects of CBT may be attenuated when used with more clinically complex populations. For example, subgroup analyses have showed that CBT may not be as effective with lower SES and possibly racially and ethnically diverse samples. So more research needs to be done on this area. The other goal that we had in doing the clinical practice guidelines was to highlight current gaps in research so that we could, in another 10 years, do another clinical practice guidelines where we would have more of the information that we feel we need. And so some of the gaps that we identified currently are that there are no RCTs of psychotherapy treatments with large enough samples of youth of color to be able to do these subgroup analyses. And only 2 RCTs to date exist that examine psychotherapy in youth of color. And there are very few or to no RCTs testing psychotherapy in diverse racial ethnic minority groups as their main focus. Other current gaps that we've identified are that there are not enough studies with more heterogeneous populations in terms of different comorbid psychiatric disorders. Efficacy studies often, one of the defining aspects of them is that they pick homogeneous populations, so they limit the number of and types of comorbidities. So by limiting that, we don't know the impact of how these treatments work with some of our more complex patients that community providers are obviously seeing in their practices. We still need to better understand personalized care, so who would do better with which treatment approach. We need to understand how sequencing treatments might improve outcomes. When should a practitioner know whether a treatment is working? By what number of sessions should they expect to see a response already to know that this treatment is going to be effective for this patient? And lastly, in addition, how does patient preference impact on the efficacy of treatment for that patient? So there are studies that suggest that if you get your preferred treatment, you have a better outcome, but we need more research on that. We also have a sense in children and adolescents that their initial preference is to start with psychotherapy. So we need more research on the impacts of preference on outcome. And lastly, we need to better understand how to make these treatments more accessible to populations where they can't so easily get to a specialized mental health clinic. So would that be doing treatments over telehealth, converting some of our treatments into online interventions? We need more research to better understand, could these types of treatment delivery systems have similarly positive outcomes as in-person therapy? So the major takeaways for the child and adolescent cohort that there's weaker evidence for the efficacy of treatments for children with depression. For adolescents, we recommend cognitive behavior therapy or interpersonal psychotherapy. CBT has benefited from the most research funding and has the largest number of studies and evidence base to date. However, other treatments may be efficacious and acceptable. However, we just don't have the evidence because they haven't been tested in the RCTs that were included in the systematic reviews. And lastly, we need more diversity of our patient populations in our clinical trials to best answer the question of what treatment will work best for which patient. And I will stop there. Thank you, and turn it over to our next speaker.
All right. Thank you, Dr. Mupson. Also, too, Dr. Mupson is a licensed clinical psychologist and professor of medical psychology in Psychiatry at Columbia University Medical Center, CUMC, Associate Director of the Division of Child and Adolescent Psychiatry, and Co-Director of the Office of Clinical Psychology at CUMC. She is also Director of Clinical Psychology and Unit Chief of the Children's Day Unit at New York State Psychiatric Institute. And now we will be moving on to our next speaker, who is Dr. Art Nezu. Dr. Nezu is Distinguished University Professor of Psychology, Professor of Medicine, and Professor of Community Health and Prevention at Drexel University. Dr. Nezu is also Editor-in-Chief of Clinical Psychology, Science and Practice, and is a member of the APA Board of Scientific Affairs. Please go ahead, Dr. Nezu.
Okay, thank you very much. Welcome, everybody. One of the pieces of information that I wanted to share with everybody provides somewhat of a context of the Clinical Practice Guidelines. I'm not sure if it was mentioned before, but this was the first target area, depression, and the other ones that exist for PTSD and childhood obesity were decided upon at a later date. And the reason why depression was first chosen, obviously, is because of its prevalence. And I'm going to be focusing somewhat on adults, as well as talk about some of the gaps in the literature. Okay. As all of you know, in terms of adult depression, major depressive disorder is the second leading cause of disability worldwide. And looking at the 2013 statistics, it had been up from the third leading cause as of the statistics in 1990. The first onset of major depressive disorder usually occurs in late teens or early adulthood. Approximately close to 7 to 7.5% of adults report an episode of major depression within a 12-month period. Unfortunately, there is a huge sex differential. Women are almost twice, 1.7 times, likely to be depressed as men. And the World Health Organization talked about the burden of depression being approximately 50% higher for women than for men. Also, research suggests that marginalized groups, for example, people of different diverse ethnicities, especially lower socioeconomic status, is likely to be higher in terms of the burden of depression. Lifetime suicide attempts is about 5 times greater with those individuals who are depressed than not. So in terms of one of the biggest predictors, or the most salient predictors of suicide amongst adults, is the diagnosis of major depressive disorder. This last point, that major depressive disorder is commonly associated with comorbidity, both psychological and medical, kind of underscores the ubiquity of depression per se, not just only in terms of it being a singular diagnostic category, but especially being associated with many other psychological, physical, and medical kinds of problems, which again, trying to put a context on this whole clinical practice guidelines. The notion is that there's many different ways within which we could have attacked or addressed CPGs for depression, and it was finally decided upon early on that this area is so large that what we needed to do is to focus on different age groups. So that's why it is being categorized by children, adolescents, adults, and older adults, as compared to depression that's comorbid, for example, with other psychological or medical disorders, for example, like cancer or heart disease. Okay. The data sources for the CPG for adults focused on 6 systematic reviews and meta-analyses, and 2 of the 6 were systematic reviews conducted by evidence-based practice centers and focused on both pharmacological versus non-pharmacological, and a very broad range of treatment comparisons. And that borrowed from the Department of Veterans Affairs Clinical Practice Guidelines for the treatment of depression. 6 of these reviews were AMSTAR evaluated. And for those of you who are unfamiliar with AMSTAR, this is an evaluation or a grading system with regard to the quality of a meta-analysis. And the 4 of these 6 focus on subclinical depression, a 3rd on short-term psychodynamic therapy, and a 4th on interpersonal psychotherapy. Okay, just in terms of the general guidelines that we developed, and what I would refer people to looking at the entire document is Table 3 for specific details. Because if I were to go into each of the different recommendations, this would take you until tomorrow at 1:30. But in general, the research that we evaluated suggested that for initial treatment, that we would recommend a certain kind of psychotherapy or a 2nd-generation antidepressant medication. And amongst those psychotherapies that were evaluated was behavior therapy, cognitive therapy, cognitive behavior therapy, mindfulness-based cognitive therapy, interpersonal psychotherapy, psychodynamic therapy, and supportive therapy. Now, as Dr. Mustin indicated before, as a function of the limitations of the research literature, it wasn't a case where, for example, any one of these 2, 3, 4, or 5 different kinds of interventions were actually compared to each other. In essence, it frequently was a case where 1 or 2 were compared to control conditions, like no treatment control or waiting list control, and as a function of them showing efficacy in comparison to these control conditions, that's why we would recommend them. If one were to consider combined treatment, what the literature suggests is to recommend cognitive behavior therapy or interpersonal psychotherapy plus a 2nd-generation antidepressant medication. Additional considerations involve, if combined treatment is considered, in essence, the literature suggests that it may be more effective than either alone. In other words, either psychotherapy by itself or psychopharmacology by itself in certain populations. But consideration is that maybe the side effect risks and patient demands may be greater. In terms of the small amount of literature that we looked at in terms of alternative and complementary medicine, the only conditional recommendation that we had was for exercise as well as St. John's wort. And again, remember that the literature is not suggesting, for example, is exercise better than cognitive therapy or psychodynamic psychotherapy or interpersonal psychotherapy, but again, it looked at research that looked at the efficacy of exercise regimens as compared to control conditions. The literature also suggests that in general, treatments for adult depression have a modest impact. And in fact, as with most psychotherapies, some patients never do get better. The last consideration is psychotherapies may be better than antidepressant medication in the longer term. But as I will talk about in the next few slides, there's not significant amount of literature to help us to be able to have any confidence in these kind of long-term recommendations. Okay. So as was initially indicated by Dr. Halfon, we were as a panel very interested in moderators of any of these outcomes, in particular with adults, but as well as the other 2 age cohorts. So for example, the literature tends to be very limited in our ability to look at differences in age, sex, ethnicity, gender identity, disability status, religion or spirituality, actual language, socioeconomic status, comorbidity with other psychological disorders or other medical disorders, as well as values. In other words, the literature does not give us the ability to say that while this particular treatment in general is effective, is it more or less effective as a function of someone's sex or ethnicity or gender identity. Another area that we considered was therapist competency. And for example, this would include the ability to tailor a particular intervention to a given individual. Also, a moderator of outcome might be access to care, the actual setting of the research, whether it was a well-controlled situation like a university hospital or a psychiatry clinic, or a private practice. Also, other moderators would be the therapeutic alliance, or the relationship between the therapist and his or her client, as well as other non-specific factors. And a big point would be patient preferences. Kind of tied to this had to do with the limitations of the research literature. Okay. There's very little comparative research. In other words, again, it becomes difficult to say if treatment A is better than treatment B, is better than treatment C. And especially, as I just mentioned, is either one of those particularly helpful for a certain subpopulation as another part of the different kind of population, again, as a function of age, gender, sex, etc. And there's a lack of focus on many therapies, so that there might be people in the audience right now that has been taught or educated in a particular therapy that has not necessarily been included in these CPGs, and that is often a function of a lack of research literature. Also, the research literature does not talk about secondary outcomes. In essence, in terms of the depression literature, we were looking at, for example, decrease in depressive symptomatology that was characterized by changes in quantitative measures, as well as changes in diagnosis. But as we become more aware of how broad the negative effects of depression as well as other psychological difficulties can be, there might be other secondary outcomes. For example, the difficulties someone has at work. So as someone becomes less depressed, does that allow him or her to go back to work and function well? Another thing that while there is some research about the long-term effects, it's very, very limited. So we don't know if a particular treatment approach that is shown to be highly effective post-treatment after a particular dose, a year, 2, or even 5 years afterwards, is there a likelihood of a second episode or a third episode of major depressive disorder? Another major limitation has to do with comorbidity, as I mentioned, and as characteristic of the literature for all 3 cohorts, there's little having to do with diverse populations. Another area of limitations has to do with harms and adverse effects. In terms of pharmacological agents, there's a likelihood that if there are negative side effects, they will be reported. But for the vast majority of research studies that focus exclusively on psychotherapy, very infrequently is it mentioned about any kind of harms or adverse effects. And one of the things that we would advocate is that we would like people to actually include just a statement, at a minimum, of that there was no harms or adverse effects. One of the things that was also very noticeable was there was poor taxonomy of therapies. This occurred especially in terms of the very, very broad umbrella of cognitive and behavioral therapies. What one study might call cognitive therapy, another study might call behavior therapy, and another study might call cognitive behavior therapy. So it becomes very difficult to actually characterize and say treatment A is better or worse than treatment B if there's huge overlaps in terms of ingredients, but even more so if the label that one uses tends to be generic as opposed to specific. Limitations of the research literature also show huge variability in the methodological rigor of the studies that tended to decrease our confidence in some of these recommendations. Also, the reporting of the results. There's a tendency for a study to even be methodologically sound or strong, that there might be a lack of results that are actually reported. So, for example, in terms of looking at different subgroups. And the last one is moderators, as I talked about before, but where actually some of the mechanisms of action having to do with why a particular treatment is effective or ineffective. So kind of underlying all psychotherapies is the notion of the theory of the therapy, and often that is not necessarily mentioned or actually assessed. So at this point, I will stop talking and allow the next speaker to go forth.
Great. Thank you, Dr. Nezu. And our next presenter is Dr. Charles Reynolds III. Dr. Reynolds is an endowed professor in geriatric psychiatry at the University of Pittsburgh Medical Center, UPMC, professor of behavioral and community health sciences at the University of Pittsburgh, and director of the Aging Institute and of the John A. Hartford Center of Excellence in Geriatric Psychiatry at UPMC and University of Pittsburgh. Please go ahead, Dr. Reynolds.
Thanks, Kelly. I'd also like to give a shout-out to two other colleagues on the APA panel whose work has profoundly influenced both this section and also other sections of our report. Geropsychologist Forrest Scogan and family medicine physician Elizabeth Lynn. In this slide, I've highlighted some of the ways that characterize the clinical scenario of depression in older adults. And by older adults, the panel generally meant those aged 60 and older, but recognizing that people live a long time after the age of 60 and age in very different ways. This slide, though, is meant to highlight some of the issues that Art has already talked about, particularly the burden of medical comorbidity and also cognitive impairment, as well as psychosocial determinants or stressors in the lives of older adults with depression, particularly involving social isolation and loneliness. The key point, though, that I'd like to emphasize, and which has already been really elegantly stated by both Laura and Art, is that the importance of screening and diagnosing and treating depression in older adults is not only to alleviate the suffering of patients and those who give them care, but also to put the odds in their favor over the long term, perhaps by using effective treatment and achieving and maintaining wellness, we can help to protect older adults from some of the terrible downstream complications of depression in later life, such as frailty, suicide, dementia, or early death. That's a really key point that I'd like to focus on. I think it may be helpful to focus on what I think of as the 3 M's of depression in older adult. Depression can be a mirror of brain aging. It can be a mediator of bad outcomes, as both Laura and Art have emphasized. It can also be a murderer, if you will, that leads to suicide and dementia. And there remain distressingly high rates of suicide amongst older adults, particularly after the age of 75. And depression is now, I think, well established as a risk factor for the onset of dementia in old age. So it may be helpful as well to take a staging model perspective, borrowing lessons from oncology, And much of the panel's work dealt with what is called indicated prevention, focusing on people with mild symptoms of depression using evidence-based short-term psychotherapies to prevent the full transition to fully syndromal major depressive episodes. At the same time, we also recognize that first episodes of major depression in old age may in fact be an early or prodromal sign of dementia. Treatment-resistant depression may increase the risk for depression, hence the importance of early intervention and definitive treatment to prevent relapse and recurrence, because with each successive episode, the risk of treatment resistance increases. So treatment goals, again, here as in earlier parts of the life cycle, symptomatic remission, facilitation of functional recovery. This is what really matters to patients and those who give them care, and reducing the risk for relapse, recurrence, and chronicity, and with it the terrible downstream sequelae that I mentioned. I like to say to my patients and their families, getting well is important, but it's not enough. It's staying well that counts. The panel focused its recommendations on the use of either group life review or reminiscence therapy or group-based cognitive behavior therapy as first-line treatments for major depression. We also suggested the efficacy, recommended the value of combined pharmacotherapy and interpersonal psychotherapy over either IPT alone or medication alone, again, emphasizing one of the points that both Laura and Art have made. Antidepressant pharmacotherapy works. However, in the short term, its effects are relatively modest, with numbers needed to treat estimated to be in the 10 to 12 range. That's a small effect. Interestingly, however, in longer-term studies, the number needed to treat in order to prevent relapse and recurrence is considerably better, on the order of 4. The important caveat, of course, is that when the treatment stops, when the pharmacotherapy stops, so does the effect. So beyond this, patients often prefer psychotherapy, particularly a learning-based form of psychotherapy, over drug-based treatments. The critical issue, I think, becomes one of access. How can we better disseminate and improve the uptake of evidence-based psychotherapy practice? What are the critical ingredients responsible for efficacy, for moderating effect, as Art has said, and can evidence-based psychotherapies perhaps be simplified and shortened? Treatment resistance is common, as I've mentioned. There is only one reasonably large study of pharmacotherapy for treatment resistance in older adults with depression, performed by my colleagues and myself and published in The Lancet. And this was a placebo-controlled evaluation of augmentation treatment with Abilify, aripiprazole, in older adults who were only partially responsive to first-line pharmacotherapy with venlafaxine, Effexor. There is, as my colleagues have emphasized, a paucity of comparative effectiveness and tolerability research on strategies involving switching or augmentation, whether of psychotherapy or pharmacotherapy. We also don't know if treating depression in older adults reduces the risk of dementia. It seems likely that that would be the case, but we lack direct experimental evidence. And we would like to know more about whether treating depression effectively in old age extends life expectancy. There is some evidence that that is indeed the case. We can also ask if depression in older adults can be prevented, in whom and how. The answer is yes. Patients with subsyndromal symptoms of depression, this is again an example of so-called indicated prevention of depression. Patients who receive depression-specific psychotherapies like CBT or IPT or problem-solving therapy indeed show a 20% reduced incidence rates of major depressive episodes over 1 to 2 years versus treatment as usual. We've also recently shown this to be the case in India in a study using problem-solving therapy for primary care in older adults attending primary care clinics in the rural and urban areas of Goa, India. Ongoing are studies of whether nutraceuticals like vitamin D and fish oils and whether interventions such as exercise may also be effective in preventing depression in older adults. So I'd like to conclude my talk by emphasizing the very important issue of access, which both Laura and, excuse me, let me get rid of that, beg your pardon. By emphasizing something that Laura and Art have already talked about, and that is how do we improve access to care. There's been considerable progress in this in studies of late life depression, and I want to highlight two paradigmatic features, two paradigmatic studies, namely the Prospect study and the Impact study, highlighted here, both published in JAMA. And I'd like to mention as well the pivotal role played by two psychologist colleagues in these studies, namely Pat Arian with the implementation of problem-solving therapy in the Impact study. Pat was a student of Art's earlier one and built on his pioneering work with problem-solving therapy in primary care. And then in the Prospect study, my colleague Charlie Schulberg and his work with interpersonal psychotherapy for depression and its implementation in primary care. The important point that I'd like to emphasize here is simply that both of these studies have shown ways of translating data from randomized clinical trials to real-world settings in primary care in a way that allows patients, older adults with major depression, to have access to evidence-based treatment and its implementation, again, in the real-world settings of primary care. So going forward, again, I think that this type of work will be very important. But to conclude my comments, I would simply emphasize the same points that Art and Laura have already emphasized, namely that we need more comparative effectiveness research in both psychotherapies and pharmacotherapies. We need to focus on issues of treatment resistance, and we need to focus on long-term studies that show how we can maintain wellness once it's achieved, and addressing as well the issue of whether long-term treatment can help to protect older adults from some of the terrible sequelae such as suicide, frailty, and dementia. I'll stop there. Thank you.
Thank you, Dr. Reynolds. Our next presenter is Ms. Vanessa Jones. Ms. Jones currently runs a Depression and Bipolar Support Alliance group. She developed in 2006 in Howard County, Maryland. She has served as an advocate and support for high school students with depression. She has spoken about her own depression and advocacy experiences with diverse groups, including psychiatric unit staff, psychiatrists, and social service departments. In addition, Ms. Jones is a certified surgical technologist. Please go ahead.
Thank you, Ms. Jones. Can you please start talking to us a little bit about the advocacy work that you do in this area?
Oh, Ms. Jones, you may have your phone on mute. If you could unmute your line, please.
I'm sorry. Good afternoon, everyone. My name is Vanessa, and I run a support group in the Howard County area that deals with people who live with depression and bipolar disorder. I bring awareness to the community about mental illness and let the community know that we are here to help. I also have done public speaking at many hospitals here in the state of Maryland, and I also have spoke at Department of Social Services here in the state of Maryland. I also currently volunteer as a court-appointed special advocate for children and youth that are in the foster care system, as being a mentor for them. And as the narrator said, I currently work in the operating room, which I do continue to promote and bring awareness to mental illness.
Thank you. And can you talk a little bit about why you agreed to be involved in developing this guideline?
I agreed. I wanted to see how a guideline was developed and what was involved. So that is one of the big reasons why I was very gung-ho to be a part of this wonderful panel.
Thank you. And how did you contribute to forming this guideline?
My contribution was my experience, because I live with depression, could help in the different elements that affected the guidelines. So far as the effects of drugs versus non-drugs, the effects of exercise versus not doing exercise when being depressed, the effects of psychotherapy versus just supportive therapy, while looking at the data as that was presented before us.
Thank you. And what do you think are the most important elements of this final document, and what else is needed?
Well, in the whole document, everything, one thing that I pulled out from it was the improvement of exercise while supporting patient cultures and values and preferences. There was not a lot of data far as information on, people having access to care for more providers. And in saying that is now what we're seeing is that a lot of consumers like myself who live with depression is not getting access to services due to the fact that the insurance companies the providers are not accepting insurances, private insurances, and that people need to come out of their pocket with money, which majority of the population cannot afford. So if that's the case, then they will not get services, and they just fall by the wayside. What I think is needed more is that in doing the research, and what is needed is that we need more up-to-date data. As all the speakers have spoke today, we really did not have a more up-to-date research that we could provide a more recommendations for.
Thank you very much. And was there anything else you wanted to add?
I just want to thank everyone, for letting me be a part of this panel. I really enjoyed all the professional people who I came involved with to give my perspective as a consumer who live with depression, another outlook. So I would just like to thank everybody at APA and the panel that I was in to allow me to be a part of this wonderful guideline.
Vanessa, we owe you thanks as well. This is Chip. The opportunity to hear your voice and what matters to you, I think, was incredibly valuable throughout our many years of deliberation. Thank you for taking the journey with us.
Thank you.
This is Art. I just also want to underscore what Chip said and the courage, Vanessa, that you showed in being transparent and upfront. I just want to say to the audience, underscore the importance of having all stakeholders involved in providing these kind of guidelines. I think sometimes we have a tendency to think that we know what we're talking about, but it becomes really important to listen to everybody. And I think that's what this guideline can offer, different perspectives.
Yeah, Art, I couldn't agree more and would add simply one point to what you said. This is Chip, and that is that these guidelines, as I understand them, and as I think Raquel emphasized, are not meant to be prescriptive. They are meant rather to inform with evidence the shared decision-making of clients, patients, and clinicians.
Thank you very much, especially big, huge thank you to Vanessa, Ms. Jones, and everyone. I'm going to go ahead and move on so we have some time I see some questions coming in. I'm going to give you a very quick tour of the Depression Guideline website. So we have this website that my colleague Mr. Jacob Marslick put a lot of time into, and the whole team of us, with various resources for you that you can access or free and publicly accessible. You see on the screen here and in your copy of your handout and your slides, here is the website link. And what I'm going to show you is a few screenshots on the website so you can get a little sense of it. We have a lot of different types of resources on there. So we have, obviously the guideline document and the appendices. And I should add, while I'm mentioning this, there's been a few questions coming in about the list of the reviews and such that were included. If you just go to this website, we've got the guideline document there, and we've got a table in there that will have all that information, has all the reviews that were used and such, and just more details about information that was included and such as well. So quickly going through, we'll have on the website, there's treatment descriptions, and those are organized by age cohort. There's also case examples, which is something that can be very helpful as you're really trying to think about applying, treatments and what it might look like with a particular client. There are some really nice examples are on here. There's a section on there for patients and family with information about the condition and assessment, treatments, barriers to treatments, where to find help, other resources. There's a really nice section on here as well for clinicians. So if you're wondering how to do some of these treatments, this is might be a good starting point for you. There's treatment manuals and assessments. There's opportunities for training and continuing education, resources, books, videos, lectures, a lot of really nice resources on here, and all available to you. And then lastly, this is just a general summary of resources. So on this slide, you can see just general information about guidelines, just general frequently asked questions. There's links here to all three of the guidelines if you just want to go directly to them. There's other resources on here as well. There's APA's Policy and Evidence-Based Practice and Psychology. There's a direct link there if you want to take a look to the reports from the Institute of Medicine. Okay, and now we are going to move on to our question and answer session. And I saw a question came in about the website link. I'm just going to put that back up on the screen. Here you go.
Thank you to our presenters. My first question is for Dr. Muffson. For the child and adolescent research, what age or age groups were used to distinguish children from adolescents?
So that's a great question. Typically, the age is 12 to 13 years of age, so 13 and up for adolescents. There were one or two studies for adolescents that did include 12-year-olds, but for the majority, it was 13 years and up.
Thank you. And again for you, Dr. Muffson, are the recommendations specifically for those with mild, moderate depression versus severe depression, especially for the youth recommendations?
So in the meta-analyses and systematic reviews, there didn't so much distinguish. We weren't able to, with the samples, distinguish so much. But if you look at some of the studies, typically for more severe depression, the combination treatment of psychotherapy and medication, really the only study that looked at combination of psychotherapy and medication is the TAD study. And so their recommendation is combination treatment worked best for more severely depressed. But in the literature, we don't have enough studies to look at different types of treatment combinations by treatment severity. But the TAD study does support the use of combination treatment for more severely depressed adolescents.
Thank you. And for Dr. Nezu, is there information on or guidelines for other treatments, such as ketamine treatment?
No, I think what I need to underscore once again was that the way in which it's important to develop the clinical practice guidelines is according to what is often referred to as the Institute of Medicine approach. And that tends to be where we actually only look at research that is methodologically sound, so that there might be case reports, or there might be some kind of research that is suggestive of other particular approaches, whether it's psychotherapy or other kind of complementary alternative medicine approaches. But given that the research literature is not there, we're unable to really comment upon that. And again, we were very restrictive in terms of how far back in time we can go, and again, the quality of either the systematic review or the meta-analysis. So my direct answer is we can't speak to that.
Thank you. And another question for Dr. Muffson. Do you know if any studies were done with children or teens that included cognitive abilities, specifically for teens who have what would be considered high IQs above 130?
As far as I know, most of our studies really don't specify for, you're talking about the more gifted kids. And so most of our studies do not limit themselves to the more higher IQ teens. It's a more general population. So we are not able, we don't have any data to make any recommendations about based on cognitive abilities, except to say that these kids that were included in these studies had to have a normal IQ or above. So it did not include kids with intellectual disabilities, but had to have a normal IQ. But beyond that, we really can't say anything.
Thank you. This question is for Dr. Reynolds. Regarding research on alternative treatments as add-ons, such as exercise, what did the research reveal about nutrition?
I think that is still an area of active interest, particularly with respect to the use of nutraceuticals like fish oils or vitamin D. In one of my own clinical trials, sponsored by NIH, which involved, this was a depression prevention trial, focusing on older black adults in Pittsburgh's East Liberty section. We found that a focus on implementing nutritional guidelines, published by the Department of Agriculture, but within the framework of problem-solving therapy, was helpful in reducing the incidence of major depressive episodes in older black patients with mild or subsyndromal symptoms of depression. Again, I would emphasize that was done within the broader context of arts work and problem-solving therapy, but with a particular focus on healthy nutrition. Currently, there is a very, very large study ongoing at Mass General led by Olivia Okerke, a geriatric psychiatrist, looking at the depression prophylactic effects of fish oil and vitamin D. And Olivia and her colleagues are looking both at universal, selective, and indicated prevention. And I think that's going to be one of the more rigorous, or will be the largest and most rigorous study of the issue highlighted by this question. So stay tuned.
Thank you. And a question for you, Ms. Jones. How did you get the schools to allow you to participate with their students?
Doing in the community by letting them know what I was doing in the community, by establishing that I had started a support group in the community, and also we in the Howard County area we have had a high incident of suicides. So by me letting them know what my purpose or my act of what I was doing, they allowed me to come in and speak with the students to help them to understand about, what is depression and the signs and the symptoms, and that we do have a support group for the high school students that they could come to. It's like a peer-to-peer support.
Thank you. And this question is actually directed at the panel as a whole. So did or will panels promulgate specific recommendations or share these recommendations for large-scale government-funded research to fill in the gaps in the evidence base?
Might be able to address that a little bit, Kelly. This is Chip Reynolds. I was mentioning to Raquel before the webinar started that a couple of us on the panel, Pim Kuipers and myself, are also engaged with the Lancet Commission on Depression. And it turns out that the goals of that commission are very closely aligned with those of the APA Depression Guideline panel. Our report, we anticipate, will be published by the Lancet in late 2020, early 21. And one of the things that we are really hoping to do is that by emphasizing the gaps in the research literature, we can influence governmental sponsors of research to focus more specifically in addressing those gaps. But at the same time, we know enough now about how to implement guidelines in real-world practice, but we need to have policies in place that support, for example, the use of telehealth or online strategies. So I think that the work that this panel has done is really going to be valuable, not only to clinicians, but also that it has the potential really to inform policymakers.
This is Art. I think that to kind of underscore what Chip just mentioned, I think that one concern that many of you might have in hearing about the limitations and what we are unable to say because of the lack of the research literature, I think one of the big values of what we did was to actually be able to very concretize what those gaps in the literature are, and to be able to put on the table, these are the areas that are greatly in need of future research. That part of me that's an advocate would strongly suggest that we all write to our Congress people and advocate that the government should put more money into that kind of research, and not just research in terms of mental health in general, but the kinds of research that, for example, the Clinical Practice Guidelines for Depression, suggests that we really, really need, for example, in terms of diverse populations, access to care, comorbidity, et cetera. So I think one of the biggest values of what we found was what we really need to look for in the future and the kind of the paths to take research-wise.
Well said, Art. Thank you.
And this is Raquel, and right before we end, I would like to make a shameless plug. So all of you will have your standard CE evaluation at the end of this webinar, but in addition, please be on the lookout in your inboxes for a very, very brief survey from APA, from Survey Gizmo, where we're going to ask you between 4 and 5 questions. It'll take you less than 5 minutes, and we want to evaluate your experience and just see how in our Clinical Practice Guidelines department we can best prepare for future webinars of this sort. So it would be, please keep an eye out. We'd really appreciate you responding to that.
Great, thank you. And that is all the time that we have for today's webinar. On behalf of the APA, we would like to thank our presenters for today's presentation, and of course, we also would like to thank you for tuning into today's program. Remember, to receive continuing education credit, please complete the evaluation. You will receive your documentation of CE credits soon after. This concludes today's presentation.